are special because of the amount of I guess flexion, extension and rotation. They're very specialised joints. As you know, the occipital condyles, sit in that curvature. The C1-2 very flat, rotates around the odontoid. Okay, Nathan, what are the uncovertebral joints? Is that special?
They're very difficult to describe.
Are they special? Any features? Sorry? Yeah, not quite anteriorly, are they? These are the famous joints of Luschka, aren't they? These are the ones that contribute to foraminal stenosis, okay? So they're special in the cervical spine, okay? So that's what's different about the cervical spine. So we look at the movement of it. You see 50% of axial rotation is at C1-2 because of that specialised joint. And the rest of any movement, and you should know the biomechanics of this, and that C0, 1, 2 are special compared to C3 to 7, which are the typical cervical vertebra. And lower down from C3 to C7, you've got about 10%, 10 degrees of movement per motion segment. Of course, C5, 6 is the most flexible, and that's why you get most of the degenerative problems there. Now, I think thoracic spine is also meant to be covered in this bone school because there was nothing else, nowhere else to put it. Again, what's special about the thoracic spine? The sagittal alignment, okay? Your end, I guess, at C7 and L1, because you're suddenly transitioning from a very flexible area to a very stiff area, okay, and they deserve special consideration when you're thinking about fixing those areas. Of course, the facets are oriented coronally, and so that's why you can get rotation. You cannot get rotation in the lumbar spine. And of course, what's also special, which always makes a lovely multi-choice question, no, I don't know whether there's one in the bank, why is the thoracic spinal cord much more prone to neurological injury? And that's because of these particular anatomical peculiarities of the thoracic spine. Anyway, revision, except to say that, as a consultant orthopaedic surgeon, you should, I guess, be approaching conditions from recognising them from the history, i.e. it's a degenerative condition, infective tumour condition, etc., etc. And your examination should be quite honed down to looking for the specific factors. The way I illustrate it and say, okay, a medical student will examine all 16 things about a lump, won't they? Size, shape, and as an orthopaedic, consultant, you're going to tell me that that lump in the thigh, okay, it's fixed, it's firm, okay, it's solid, it's a tumour until proven otherwise. Pertinent, just the pertinent positives. Okay. Just remember the nerve roots produce radiculopathies, and the spinal cord will produce syndromes and upper motor neuron signs. Okay, now we've got to talk about, I guess, osteoarthritis, degeneration of the spine. Okay, so we all know that we all get degeneration as we get older. The more mobile areas, of course, are going to wear out even faster. Is there a correlation with radiology? Probably not, we know that. Okay, pathophysiology. This is the pathophysiology of osteoarthritis, so I don't really need to go through that, except to say that you can see that we get a lot of changes at the uncovertebral joint, so that's why you have to know about them, and that's what produces your radiculopathy, isn't it? You can get something called hard disc in the neck. Okay, so in terms of clinical, what should you pick up in clinic? You should know that there are 3 different clinical syndromes. You can get axial, and this is the same in the lumbar spine as well, okay? Axial pain, neck pain, back pain, thoracic pain, just central pain. And this is our osteoarthritis, disc degeneration, physiological ageing, whatever you like to call it. And also, I guess, in the thoracic spine, what we would know as Sherman's changes just on radiology. Okay, so there's the axial pain syndrome. Then there's the radicular pain syndrome, and this is what you know as your disc prolapse, for want of a better term, or your foraminal stenosis, or your spinal canal stenosis with foraminal components. Okay, and then the third syndrome, which is not so much a pain syndrome but more of a neurological syndrome, is your myelopathy. And I think if you think of all the degenerative syndromes under these clinical syndromes, it's much easier to think about. Okay, so if we first look at what we call neck pain or back pain, it's just axial pain, there's no neurology, you get referred pain, but you do not get radicular pain, do you? Okay, what we were trying to get before, the natural history of this. A lot of people will get episodes of neck pain, but there'll be a certain percentage who have an episode of neck pain and it'll settle down completely. Some will get a sort of fluctuating pathway, and some will just remain with chronic neck pain. It's the same in the back, isn't it? Pretty much the same. Okay, when you're treating these are not, very sort of satisfying to treat, as you know. However, it is more satisfying to treat than your lumbar spine pain syndromes. And I guess, what we're saying is if you're thinking about going down along the operative pathway and considering it, if you get it right, you might at best do 60%, get a 60% success rate, which is actually much better than treating lumbar spine pain. Okay, and this is the sort of thing, I guess, that we see. On the left there is your normal neck progressing to the changes of spondylosis. Of course, there's a classification, and there's the phases of osteoarthritis, okay, which are applicable, to any joint that can degenerate. And again, I'd expect you to know all these patho changes because you've all done the reading, haven't you? Okay. All right. I just wanted to just briefly mention scoliosis and kyphosis. The girl on the left there, you can see, has got a scoliosis. The boy on the right, he's got an abnormal thoracic kyphosis. He's also got increased sway, hasn't he? Increased lumbar lordosis as well. And that's how you pick these up, the forward bend test. Okay, just so you see them. And I guess the big question is, do these conditions, actually lead to this degenerative axial pain syndrome or not? Now, I guess it's been said that the scoliosis don't tend to go to lumbar spine pain. The thoracic scoliosis don't tend to go to thoracic spine pain, and by and large, and the Shermans as well, don't commonly progress to thoracic spine pain. And in my practice, I would say that probably holds true. Would you say that, Greg? You don't see a lot of these deformities turning up, funnily enough, with that axial pain syndrome. Occasionally, you might see the scoliotics turn up with a radicular pain in one of those curvatures. Okay, so let's look quickly at radiculopathy. Okay, radiculopathy usually refers to the radicular pain, which is in that nerve root. Sorry, you need to know your dermatomes and myotomes, obviously. The pathophysiology is that it can be soft disc or it can be hard disc, which is an osteophyte off those uncovertible joints, can't it? And they're commonly at the more mobile levels. Okay. Patient who comes with a radiculopathy, you can tell them, yes, no, it's not, you're not going to be paralysed. Okay. A lot of them do have persisting symptoms, but again, if you go back to that paper of Weaver, they say 75% will settle down within 3 months, which is a lot less optimistic than what Glenn just said before. And that's, probably true. Now, when you say persisting symptoms, the persisting symptoms may be disabling or they may be annoying, obviously. But that means that, a good 40, maybe 50% will settle down without surgery. And just to prove the point, that's an old paper that said that, athletes, even athletes treated conservatively will, settle down and are able to get back to sport. Treating these are the most, I guess, satisfying, the most predictable if they come to surgery. And, again, what McNabb said, you operate on the right patient for the right diagnosis and you get the right level. It is a very satisfying operation. Don't need to remind you about the, where the nerve roots come out. You should know that, but in the cervical spine they come out above their own vertebra. And then the type of disc herniation, apart from the bulge, the extrusion and the sequestration, just, where they are, posterolaterally, centrally, which is actually quite uncommon, less common than posterolaterally, and of course there's far lateral. This is probably not quite far lateral enough to be called far lateral. It's right in the foramen. Okay, so there's your typical soft disc. Okay, this was a 40-year-old policewoman who, I guess, presented after a fall chasing crooks. She was largely sort of asymptomatic, but we were just a bit worried about the largeness of that disc prolapse. Nonetheless, what we were trying to point out here is you can see at the ripe old age of 40, she's already started to get this, this tendency to degenerative change. Her discs are a little bit dark. This is a T2, of course. Okay, and you can see, okay, you've got to know the difference between effacement and compression of the cord, and I think I went through that with you set ones the other day as well. You've got to also speak. And you can see it coming back here. So there's your typical soft disc. Now here are the signs of, I guess, a bit more of a hard disc on the X-rays, and what these arrows here, well, that's a spur, but this is pointing to the foraminal stenosis. It doesn't project very well, but you can see here's an open foramen, and if you look at the oblique X-rays, you'll be able to see osteophytes coming off the joints of Luschka and narrowing that foramen. This is pointing just to a CT scan of a soft disc, and here we are with a hard disc, which is just essentially osteophyte, off that joint there. Okay, if we just mention also the thoracic spine while we're here, here's a soft disc coming out the back here, disc material displacing the epidural sac here in each level. And here you can see an obvious hard disc with the spur coming back out into the canal there. Okay, the third clinical syndrome, myelopathy. That can produce pure cord compression with no pain, but they often get sort of an aching axial pain syndrome. But the predominant thing is they're either starting to drop things, they're starting to lose balance, etc., etc. Now these produce spinal cord syndromes by and large, and you should have a bit of an idea of what they sort of are. Myelopathy, we talk about, I guess, Neuric has got a grading for that, and I won't dwell on that, but you probably should have an idea of how to grade a myelopathy. Okay, there's also the Japanese Orthopaedic Association one, which involves, being able to use chopsticks or not. So, we could, I guess, that's very easy to apply in Australia, of course, yeah. Okay, so the natural history of this is it often can be a stepwise progression rather than a gradual progression. But even, again, it's only a very small proportion that I guess are really sort of, at risk of progressing very, very fast. Trouble is, of course, you don't know who they are. Okay, if you operate on them, which is, I guess, by and large, a good idea once they've come to you because the symptoms are usually significant enough. These are the patients that do well. In terms of regaining any neurological deficit, in general, the prognosis for regaining their normal neurology is sort of moderately poor. Okay, and there's your typical patient with your multi-level stenosis. He's still got a bit of lordosis here, which is quite, I guess, not as common. People tend to lose their lordosis when they get a bit of degeneration. Now here's this rare, I guess, patient who, in fact, knew he had Sherman's disease as a teenager, and unfortunately, I guess, as he got older and he did progress very slightly, it was enough to stretch his cord over that kyphosis and for him to develop a myelopathy. And that's very, very uncommon though. Okay, so if you operate on any of these conditions, you really must make sure that, you know, after you've done your history, you've got the diagnosis in mind, that your investigations really stack up to support your hypothesis that, you know, there's a surgical condition here. So your indications: persistent radicular pain that's not responsive to conservative management, or neurology, essentially. Okay, that's much of the same thing. I guess there's a lot of philosophy you can talk about whether you should go front or back. And basically that's your armamentarium of operations that you've got available, and we obviously don't have time in the 15 minutes to go through each and every one of those different things, except to say, you know, we as orthopaedic surgeons would never do an anterior discectomy alone. That's a neurosurgical operation. You can just do a discectomy in the cervical spine. The problem is they get they don't become unstable, but what actually happens is they get a lot of neck pain down the track. In terms of laminectomy, you should never do a laminectomy alone in the cervical spine or the thoracic spine. In the cervical spine, you often end up with the kyphosis. Okay, in the thoracic spine, you do a laminectomy, especially in the presence of some sort of disc prolapse or something at the front. You've got a 20% incidence of paraplegia because you're just letting them come a bit more kyphotic, and it's just too much for the cervical spine. If you do a laminectomy in either the neck or the thoracic spine, you must instrument them. Okay, and you've probably seen pictures of most of these. Non-instrumented fusion on the left, which is what I still do for degenerative conditions, unless there's a reason to use a plate. I can't get the stability, etc., etc. I don't do total disc replacement. I consider that experimental. Greg? Yes, two disc space. I'll still do a non-instrumented.
So you only non-instrumented if you're a single.
Sorry,
You're only not instrumented.
No, I'll do a double level as well.
So
If I'm happy, yeah, I can get the fix by doing the proper carpentry. Yeah. Greg, did you want to say anything about disc replacement in the neck?
Short term, it gives. The good thing about this particular condition is that almost any operation you do gets good results.
Much more satisfying to treat than the lumbar spine. Yeah. Okay. Oh, and I don't have a picture of a. Oh, that's a laminoplasty, but I guess orthopaedic surgeons too versus neurosurgeons, we don't tend to do too many foraminotomies. Okay, from behind. I didn't put a picture of that in there. Sorry, I forgot. But I think an ACDF has got such good results. If you're looking at radiculopathy, okay, an ACDF has such good results in soft or hard disc compared to foraminotomy, and this paper by Harry Herkowitz, you know, supports that too. And I think most I mean, we almost invariably right around Australia would do ACDFs for this condition rather than a foraminotomy. A lot of neurosurgeons would be half in practice. Okay, there's a picture of your laminoplasty. This is, I guess, what I do. I do a one-sided open door laminoplasty. Greg, what technique do you use for your laminoplasty? You do one-sided, you open the middle. Yeah. I open them with the spinous processors, but there's a lot of expensive tiny little plates you can buy to prop them open. And then lastly, if you do a laminectomy, you should fix them, and that's obviously with some lateral mass screws. You can see here, this is where your screws go across the lateral mass, so you should not put it into the vertebral artery. And it's better to use the what's called the Magel technique, where you don't put it straight into the nerve root there, and line it up along the facet joints. Okay, so in summary, you've got axial pain, radicular pain, myelopathy, and don't forget a midline disc prolapse is important because it's going to cause a spinal cord injury. Nonetheless, you've got some important things, you know, in other bits of the spinal cord. And don't forget there is a, you know, referred pain or pain from other areas that can mimic cervical radiculopathy. I expect you to know about all those entrapment syndromes that I've got listed there, of course. Thoracic outlet syndrome, and of course, you know, the shoulder and the neck, you know, together are always in your differential diagnosis for pain around there, aren't they? Okay, so there's, I guess, your operative outcomes. As I said, 60%, that's a pretty good figure. If you pick the right patient, you actually get some fairly satisfied customers, unlike the lumbar spine. Radiculopathy for you know, disc prolapse, even better outcome rate. And for myelopathy, you know, what you're aiming to do is stop the progression of any neurology. Okay, so there's that. All right, and I think I'm supposed to talk about ankylosing spondylitis. It's a very long talk, and you'll probably get very bored. We'll see how we go, and I'll try and make up some. I guess I probably don't need to tell you about the spondyloarthritis because, you know, I guess in a sense it's sort of boring for us, but I think you probably ought to know, I guess, a bit about the medical side of things, which is what I'm going to try and teach you now. So characteristic features of any spondyloarthritis, of which ankylosing spondylitis is one, are all these things. So this is your quick medical tute on everything you need to know about ankylosing spondylitis and spondyloarthritis, and we'll never need to read again, hopefully. All right, so first of all, you get inflammatory back pain. And there are certain definitions that the rheumatologists use about, you know, night pain, about stiffness, etc., etc. And this is just showing that the probability that you've got ankylosing spondylitis increases as you take on each, you know, one of these definitions. And it's like rheumatoid arthritis, you know, there's criteria that you've got to meet to make it ankylosing spondylitis, and there's a very complicated rheumatological algorithm for diagnosing ankylosing spondylitis. All right, so they get an asymmetric peripheral arthritis. They get an enthesitis, okay? So they, you know, plantar fasciitis is incredibly common in patients with ankylosing spondylitis, okay? And there's actually a score that you can apply to them. And of course you can see any place that a tendon attaches, you can ask them about, you know, getting inflammatory symptoms of that, around that area. They get a dactylitis, and they get iritis and, you know, skin lesions. That's psoriasis, of course, and that's an iritis. Okay, they get inflammation about the iris, which causes adhesions, and that's why you get that irregularity there. Of course, the absolute thing about ankylosing spondylitis is the sacroiliitis, isn't it? Okay, so you all know what a Ferguson X-ray view is, don't you? A special AP view of the sacrum. Okay, and there it is there, and that's what you need to look at your SI joints, okay? And there's also a classification system for that, of which you've got ranging from just, I guess, a normal X-ray, as we saw first, through all the different inflammatory changes as the ankylosing spondylitis is evolving. So how do you diagnose it? You've got to have these criteria, just like rheumatoid arthritis. Okay, and so you can see here that, you know, your sacroiliitis really has to be, you know, moderately advanced. Okay, the relationship of HLA B27. I mean, as you know, it's a disease of young males, and this is the HLA B27 is, you know, reasonably sensitive in young males with back pain, and that relates back to that algorithm I told you about. If you satisfy all that criteria and you come down the triangle, this is one thing that makes it much more likely that you've got ankylosing spondylitis. And this is how you, I guess, make this is just really the epidemiology, most of which you know. But keep in mind that they do get osteoporotic. They do have fracture risks because of that and because of the stiffness. But the main thing is that they do actually heal okay. Diagnosis is often delayed, and it may be sometimes that you may be the first one that picks it up. Those with more severe disease have poor response to the NSAIDs. They obviously, I guess, have severe lumbar spine disease early, and they have extra articular features. And the younger the onset, also I guess the worse the prognosis in general. And these patients with ankylosing spondylitis, virtually all of them have some hip arthritis. It depends how bad it is. When you see them early and they're in the inflammatory phase, what you've got to, I think our job as orthopaedic surgeons is to prevent them, going into a deformed position. And so the patients that I've seen early with ankylosing spondylitis, I'll be telling them to modify their lifestyle. And one of the things that I tell them to do is to organise to lie down in the middle of the day. They shouldn't be doing occupations that are forever bending over, because if they're going to stiffen, you want them to stiffen in a straight position. The other aspect of this, which is not in here either, is they get a myositis, and that doesn't help their weakness during the day as the day progresses as well. So it's extension exercises you need to prescribe for them. The drugs, of course, we leave to the rheumatologist, but you do need to be, aware of the DIMARDs, and now you need to be aware of, the tumour necrosis factors, which are really have revolutionised the treatment of all of these, but especially ankylosing spondylitis. And you will have heard of Enbrel and Humira. They're two very common TNFs that are around. Okay, so now we get to so that's all you need to know about the medical thing, so now you know. If we look at the bony side of things, as you know, affects the spine and the large joints, primarily the hips. And the thing about ankylosing spondylitis, okay, there's never any skip lesions, are there? You've got to go from the sacroiliac joint up, and it doesn't miss anything along the way. What do you get in this? You tend to get flexion deformities, and then it slowly works its way right up to the neck. Often the C01 is spared, fortunately, but it will certainly progress right up to that area. Now, as a result of all these, you can get a spondylodiscitis because it, as you know, it fuses with syndesmophytes. The disc is still present, and you get an inflammatory reaction there, and so you get like a pseudarthrosis at the disc space, which of course can be a disaster if you've got too long lever arms. And that's the only way where you'll see an apparent skip lesion if it's a spondylodiscitis. Syndesmophytes, as you know, the reason I told you, of course, about the enthesiopathy is because really, the syndesmophytes and these things in the spine is really an enthesiopathy, isn't it? It's that inflammation and then calcification of Sharpie's fibres in the spine, and that's what makes it different from the dish. So there you are. You see the flowing, very straight syndesmophytes evolution in the spine and ankylosing spondylitis there, as opposed to dish, okay, where you see you've got skip lesions, you've got these huge osteophytes, which are not originating from the same place as where your syndesmophytes of ankylosing spondylitis are coming from. Okay, so where are we called in when there's deformity? Primarily the hips. Next most common is the lumbar spine, and then probably the cervical spine rather than the thoracic spine. Okay, and this is the evolution of what tends to happen with gravity and age. And okay, I did a fellowship in Buffalo. What I'm going to do is just run through, I guess, some of these deformities, which I think some of you have seen because I like showing these x-rays. So there's a typical cervical deformity, and you can see what's happened here. And a lot of these patients present because they've had a fracture, and that's after a cervical osteotomy. This is primarily a thoracic one. One thing we measure in clinical examination, you can stand these patients up against a wall and you can measure that distance, or you can measure the chin-brow angle across there. There's some objective ways of measuring their deformity. That's primarily thoracic spine deformity, which by and large needs to be corrected with anterior release and posterior osteotomy is the only way to get them moving. This was a case of somebody from Louisiana who got around looking through his legs. He had, you can see the deformities at every level, including his spine, including his hips. So the trouble was, you know, doing his hips first actually meant that he couldn't either see through his legs anymore. So he required a huge lumbar osteotomy to get him upright. You can't quite see there, but you can see how open that osteotomy is there, and that was essentially fractured in the front. So you can actually help them stand up a bit. This is the same guy after his hip replacements, of course. And I guess my last message is, you know, when you see somebody with ankylosing spondylitis, you know, and they've had a trauma and you think that they've had a fracture, look hard, because if they have and you know, and you leave them, this is how you get these progressive cervical or thoracic deformities. And so you really need a low index of suspicion of somebody who's got ankylosing spondylitis, who's been in, you know, any sort of accident. Remember that they're highly unstable, and you need to stabilise them, whether that's with external means or plus or minus eventually internal means as soon as possible. And if you can hold them there, they do heal up. Okay, and there should, I guess, this is a patient with dish rather than ankylosing spondylitis, but you can see the tendency to have these 3-column unstable fractures. And unless you look for this one in the back, that can often be missed because it can often be very subtle.